Hey, hello everyone. My name is Rabia Khan. I am one of the third-year residents at Internal Medicine program in Wellstar, Kennestone, which is outside Atlanta. Um, it's really good to see all of you here. I am usually nervous at this stage, so I hope you guys are the forgiving audience. Okay. And there has been very amazing content shared, so I hope I can keep the momentum. So let's just get right into the case. Okay, so my patient was a 39-year-old female. She was admitted for 3 days of worsening lethargy, drowsiness, confusion, and changes in her speech. Her medical history was pertinent for a cutaneous T-cell lymphoma, hypothyroidism, hypertension, and a recent hospitalization for sepsis secondary to non-hemolytic streptococcemia, bacteremia, and new onset seizure. When it comes to her T-cell lymphoma, she was treated with Bexarotene. That was for almost a year, but it was stopped when she was recently hospitalized. And when she restarted Bexarotene, then she developed the symptoms that she presented with. So her vitals, you can see she was hypothermic when she presented, a little tachypneic and hypertensive with systolics in 150s to 70, but she was setting well in the room air. Physical exam, the pertinent physical exam was positive that she was looking very ill. She was not alert oriented to person, place, or time. She could not converse, but there was no focal neurological findings, but that was limited, the neuro exam. So these are some of the pertinent labs. Again, the normal ones I've not included. So her TSH, you guys can see it was elevated. The ACTH assay was positive, but it's sort of like not too high, but not too low either. It prompted us to get the baseline cortisol. Again, that's sort of indeterminate, like not too high, not too low. And then we did the cosintropin stimulation test. So at 30 and 60-minute cortisol continue to stay low. This alone, ACTH and cortisol, leads us toward the diagnosis of adrenal insufficiency. We wanted to make sure we check out their hormones. FSH, LH is normal. DHEAS is on the low side. In general, it actually presents that your adrenals are not making enough hormones. Prolactin a little bit on the lower side. Now, after the labs, it prompted us to get certain imagings, considering she came in with altered mental status. So CT head was, without contrast, was unremarkable. She had a recent history of seizures, so we wanted to make sure there's no seizures, so EEG was normal. And then MRI showed a 4-millimeter microadenoma. That was very small. There was no mass effects, and we know that was not functional. Prolactin was almost normal. So her treatment, while she was there, we started on IV hydrocortisone at 10 milligrams, and it was tapered down over a week. And that actually helped her in her clinical improvement. She was discharged on oral hydrocortisone 10 milligrams twice daily for adrenal insufficiency. We also ended up adjusting her thyroxine dose. She used to be on 50 micrograms, and we increased it to 100. Then she was also instructed to stop Bexarotene indefinitely, as it basically was suspecting cause of her symptoms. We asked her to follow up with an oncologist to look for any alternative treatment. So we know the diagnosis to adrenal insufficiency that was new, and then her poorly controlled hypothyroidism. Now this case investigates adrenal insufficiency. That's a very rare side of Bexarotene, and we managed it in patient. What is Bexarotene? It is a retinoid that selectively activates retinoid X receptors and induces cell differentiation in apoptosis. Now, it's currently approved for treating T-cell lymphoma, but it's under investigation. There's research going on for it to be used for lung, breast, and thyroid cancers. Most common side effects that we had known so far was skin reactions, hypertriglyceridemia, central hypothyroidism, but adrenal insufficiency is often overlooked. Hospitals should have a high index of suspicion for adrenal failure in patients under Bexarotene therapy. We want to make sure we are monitoring the cortisol levels, especially in those patients who develop with these symptoms. These are my references. And if you guys have any questions, I'll be presenting another case.